So we're ready to go, Scott?
I think we're ready to go.
Great, thank you. First of all, welcome to our AI task force meeting. For those of you on Zoom, you can see that many of us are gathered here in person. And for those in the room, it's great to see you in person. We welcome our online guests. This meeting is obviously being participated in both jointly, both virtually and in person. I'll give you a little bit of housekeeping first. First and foremost, I want to thank Dan Nygren and his team at Maine Health for hosting what was an excellent presentation on AI in use here at Maine Health. So thank you very much. For those of you joining us by Zoom, the task force members and technical advisors should be showing up as panelists. So if you don't see yourself as a panelist, get in touch with either Scott or Dan and they will promote you. That will be the fastest promotion you'll ever get. And as you may have heard at the very beginning, the meeting is being recorded. Now you can access the recordings of prior meetings on the AI Task Force website, which you get to via the Governor's Office for Policy Innovation in the Future. Finally, to my left, I want to welcome our newest member, Sarah Curran. Sarah is the new director of GoPIF, and Sarah steps in as Hannah Pingree has stepped out last month. So welcome, Sarah.
Thank
We pass on our appreciation to Hannah for her great support, and we look forward to working with you. Welcome and thank you. On to the agenda for today's meeting. Today, we're focusing on the implications of AI in healthcare in Maine. And first, we're going to have a panel discussion with two physicians and a national expert about how AI tools are making their way into clinical spaces. We've actually just seen a bit of an example on that. We'll also look at how AI is helping support administrative offices. We'll hear about the opportunities AI presents for improving patient outcomes and, importantly, physician satisfaction, as well as introducing some of the challenges that may exist around adopting AI in healthcare settings. That panel will be followed, we hope, with a short presentation by Dr. Nick Jacobson. Dr. Jacobson is a Dartmouth researcher and a psychiatrist. He recently published the first and most rigorous study to date on the impact of AI on mental health needs. We invited Dr. Jacobson to join us because access to mental health in Maine is such a significant challenge, especially in our rural communities. You know, by one estimate, there were more than 10,000 people who were on wait lists for mental health services in 2000. We'll hear both about the promise of AI to address such gaps and the substantial work that remains to make those resources safe, accessible solutions. We have a tight window, so I am going to monitor the clock a bit, and we'll be thrilled to have Dr. Jacobson join us. Shortly after Dr. Jacobson's presentation, we'll take a short break, then we'll come back and we will have wrap up and discussion. Mary and I have also, at the end of the day, asked Scott from the GoPIF team to preview our plan for work this summer and into the fall, because we have an October 31st reporting deadline. But we'll be sure to have everybody on their way by 4 o'clock. So for us to get started, I would like to introduce Lisa Letourneau from Maine's Department of Health and Human Services. And Lisa will be facilitating panel discussion. So Lisa, I'm going to turn the floor over to you.
Great, thanks so much. Thanks everybody for joining. So I'm Lisa Letourneau. I'm an internist by background and currently serve as a senior advisor for delivery system change at Maine DHHS. I actually share a seat, sort of stand in for Commissioner Diane Holmes, who sends her apologies today that she's not able to make it, and have been working with Scott and Dan for about the past year now. Can't believe it's been a year on issues related to AI and healthcare. So just really pleased today to be here with that focus of the meeting today, and very pleased to have these panel members, as mentioned here, to talk with us. So we have Dr. Rebecca Hemphill, Dr. Todd Kitchens, and Dr. Mark Sendak, who's going to join us here virtually. And I'm going to start off by asking you each to just introduce yourself briefly, your name, your organization, a sentence or two of your background with AI, and then we're going to go through and ask more specific questions. So Mark, I'll start since you're right there on the screen with us.
So it's a pleasure to be here. It was wonderful to meet with Dan and the Maine team. I would say that you're even further ahead than many other states that we're interacting with in terms of thinking about how to bring AI to rural communities. So my name is Mark Sendak. I work at the Duke Institute for Health Innovation. The other hat that I wear that's relevant to this conversation is I'm the co-lead for Health AI Partnership. I spent the first 7 years at DHI really being a developer of AI systems, implementer of those systems within Duke. And then the last 3 years helping lead a national collaborative doing technical assistance and capacity building for AI capabilities in community hospitals and community health centers. So pleasure to be here and very excited to be working with a group like you looking at how to do this work at a state level.
Great, thanks. We'll get back to you with some questions in just a minute. And then Rebecca?
Yeah. Hi, Rebecca Hemphill. I'm a practicing primary care internal medicine physician and the Chief Medical Information Officer for Maine Health. I've been in that role for 4 years now. I've been in Maine Health for 25 years. And in my work, I work closely with the IT team and Dan, as well as clinical leadership operations to bring technology to the front lines, including AI. And we'll dig more into some of our projects in I assume.
And then Dr. Todd Kitchens.
Thank you, Lisa. First, I have to ask, the task force tolerate about 60 to 90 seconds of a prepared statement? Because if so, I would really like to do that. I think it would set the stage nicely for really, thinking about how people on the front lines of healthcare in rural communities here in Maine are using this technology, and I think it might help to craft the conversations. That'd be okay.
Sure.
Very brief.
I was going to say, doing it as part, we get to you in the.
Oh, I'm happy to do it whenever you would like. Oh, I'm Todd Kitchens. I'm the Chief Medical Officer at Saucony Valley Health Center, Medical Director as well. And I've been doing this kind of stuff for a long time. Well, AI hasn't been around that long, at least not in the public domain. But I do have a background in software development and coding. There's that. So I'm happy to be here, happy to be of service, and we'll see more.
Great, thanks. So then I'm going to turn back. I'm going to start with Rebecca. Those of you who are in the room heard Dr. Hemphill talk about her work using tools to do this ambient documentation. But you've really been at the forefront of piloting some of these generative AI tools. So wondering if you could talk a little bit more about that and what are some of the most exciting impacts that you've seen on using those tools in the pilot way, and I think now more broadly across the system.
Yeah, thanks, Lisa. So the sort of highest profile and highest impact project that I've been involved in with regards to AI is the ambient listening project that I've had the opportunity to demo in the last hour. And in that work, it's really been one of the most rewarding projects that I've had the opportunity to work on in my role as Chief Medical Information Officer, in that it has made a tremendous impact to the clinicians that are using this tool. For those that are not as familiar with it, it's a tool that supports clinicians with their clinical documentation during the visit, recording the conversation and morphing that recording into a meaningful clinical note. I will say that, and we touched on this in our earlier discussion, it's critically important that the clinician reviews the content of what gets created by the tool, but it has a tremendous impact in enabling the physician or clinician to take their hands off the keyboard, turn and face the patient, and really make a high quality conversation during a patient visit. And it really enhances the quality of that visit, both for the patient and for the clinician, and reduces the sort of burden of documentation. I think for those of us in the room who have suffered through the documentation requirements, it can be challenging when you have a busy day and not a lot of time to spend with your patients. This is a tool that has really had a huge impact for our clinicians. And I mentioned earlier that this is, in my role, I usually just hear from people when things are broken or not going well or creating challenges. And in this work, I hear from people because I've had this project in particular has had such a tremendous positive impact that's brought back the joy in practicing medicine. It's enabled people to stay in medicine where they might have left or thought about retirement, or reduced clinical time, all of these things. So as we here in Maine think about how do we retain our clinicians, attract our clinicians, I think this will be an important tool to support that.
And on the patient side, so you mentioned measures of provider satisfaction, provider retention.
So early on in our project, where we were still in a pilot phase, I should mention that we started as a pilot a couple of years ago, and we now have the tool. I think we're upwards of over 400 of our clinicians currently using the tool in all of our regions, in most of our specialties. So this has really been broadly spread across the system. Early on in our pilot, we actually had patient surveys at the end of visits, so that we could, in addition to surveying physicians and their experience with using the tool, it was important for us to get data from the patients as well. And far and away, all the patients spoke very highly of the patients. Noticed that the doctor's paying more attention, they weren't having to type as much, and they really had the impression that the doctor was listening to them much better and the quality of the visit was better. So that's what we heard from patients as well.
Perfect. And we'll have time for more discussion and questions afterwards, but I'm going to keep going. We also, I think, Mark, you have a hard stop at a certain 2:45, I think, so we'll try to respect that time. But onto a smaller system. So Dr. Todd Kitchens with Shakopee Valley, a federally qualified health center in a rural area of Maine. I'm curious to hear what this work has looked like in that sort of area. And certainly if you want to start off with your statement.
Sure. Great. Thank you again, Lisa. And just to
Might want to speak right up.
Sure. And just to start right from the top, good afternoon, everyone. Thanks for the invite. I really do appreciate it. Appreciate the opportunity. I'm Todd Kitchens, Chief Medical Officer at Shakopee Valley Health Center, a federally qualified health center that serves over 6,000 patients across 18 rural communities in Maine and New Hampshire. I'm here to share what AI looks like on the front lines of healthcare delivery, not in academic medical centers or large hospital systems, but in the community health centers that serve as the safety net for Maine's most vulnerable populations. Let me give you one concrete example of AI's impact. This year, we used AI to conduct a systematic diabetes care audit across our patient population. The results were striking. We achieved a 36.9% average improvement across all quality metrics. A1C target documentation went from, even more strikingly, 0 to 100%. Again, now that's not A1C documentation, that's A1C target documentation, just for clarity. And appropriate GLP-1 therapy increased by 43.5%. These aren't just numbers. They represent better care for patients with diabetes who might otherwise face complications. But here's what I've learned. Successful AI adoption requires more than just good technology. It requires thoughtful governance that balances innovation with protection. At SBAC, we've implemented what I call a trust-based network. We use HIPAA-compliant tools where every AI interaction requires direct provider involvement. Our providers generate prompts, review outputs, and reconcile AI insights with their clinical judgment. It's like having a specialist available to curbside consults or an additional preceptor to supplement decision-making, which I really appreciate. The policy opportunity for Maine is to create a risk-based regulatory approach that protects patients without stifling innovation. That could transform rural healthcare. We need frameworks that ensure AI tools are validated on Maine's unique populations, our rural, aging, economically diverse communities, not just urban data sets. We need clarity on liability so providers feel confident adopting these tools. And we need equity impact assessments to ensure AI doesn't worsen the disparities we're working to eliminate. Community health centers have historically been testing grounds for healthcare innovations that later inform broader policy. With the right governance framework, Maine can lead the nation in responsible AI adoption that truly serves all of our communities. And with that, I'll stop there and take any questions or.
Maybe just a little bit more about what that governance looks like in a rural community and small setting.
Well, that's a great question because it's a moving target. It's fast evolving. The technology is different now than it was when I walked into the church. Right. So the governance framework, if you will, within our health center is very much tied to policy and procedure development, which is currently in an iterative process of development. But what I did to really kick things off is to create essentially a user guide for providers with very clear guardrails of what tools can be used, how they can be used, in what situations, how to design prompts to get reliable results, how to reconcile those with your own thinking, how to not simply just take the output and do what it says because hey, it sounds good, but to actually reconcile that with your own judgment, which may actually be coming and precepting with me or precepting with we use another service called Picasso MD for remote point of care curbsides as well. So the AI tools have really become like the first line interaction that providers take when they have a clinical question that they don't know the answers to, or they need their own assessments or differentials or therapeutic ideas validated before they take action. So it's really not meant to be used blindly, but to be used to validate and enhance. And they're really counseled and expected to use it not as a tool. I teach them to use it as a collaborative partner. I think that's one of the key features of AI is that once you actually transition from using AI as a tool to using AI as a clinical partner, the quality of the responses dramatically improves, which is kind of magical in a weird way. But as soon as you start talking to it in a way that allows it to have some creative process in its response, the quality of its responses and accuracy dramatically improves. So that's a bit of a cultural shift, right? To talk to a computer as you would another colleague, but that's what it requires. So again, it's really more of a where the rubber meets the road. This is how to do it, while the slow churn of policy and procedure takes shape at the leadership level, which I'm participating in. And then also at the ACO level, we have a new AI
Accountable
governance.
Care Organization.
The Accountable Care Organization, Community Care Partners of Maine, which is the largest ACO in the state of Maine, representing 17 health centers and about 100,000 patient lives. So it's quite large ACO. So they have a new AI governance committee, which I'm the chair, but we haven't even had our meeting. So it's all of this is very new and in process. The one other thing I will add is that yes, this improves providers' lives. It improves their quality of documentation. It improves their clinical decision making. Makes my life easier because I don't have to precept as many cases. But the use of AI for clinical decision making is just scratching the surface of its capability. It's actually kind of a simple task to ask it. It is much better and, dare I say, happier when you have it do much more complex tasks. For example, one of the things we're working on right now is completely revamping our entire policy and procedure. Our policy and procedure folder, which I'm sure you can imagine how many documents are in there. And to simply ask it to review, identify discrepancies and risk exposure based on compliance gaps within our policy framework. And it knows exactly which regulatory organizations that we are responsible to report to, and they're up to date on their fine structure, the reporting requirements, when to report, and then within 30 seconds can generate a 3-phase audit and work plan to tell you exactly how to align every single policy within your organization. So
A lot of
tremendous.
A lot of different ways to use it. So thank you.
So yeah, there's a lot of opportunity.
So moving on from this question, really particularly of how small
Lisa,
organizations.
can you speak up a little bit?
Yeah, so just building off of the comments about being a small organization, rural community, the importance of governance, going to turn to Mark, knowing that that is related to the work you're doing at Duke. So can you tell us a little bit more about your work at Duke and the HAI partnership and how that relates to some of the work we're doing here in Maine?
Yes, and Lisa, I have to call out that I saw you on the session last week. So when I joined, it was did you join the session with Michigan?
Yep.
Yes. So thank you for participating. So most of my career here at Duke has been internally focused. We are an internal R&D team where we work with frontline clinicians to source problems, and then we build and implement solutions with those clinicians to improve care delivery for Duke patients. And for many years, we were fortunate to have very strong senior leadership support, and we kind of got ahead of the pack, per se, in terms of the speed with which we were building and implementing AI solutions. And so today, for example, over the years, we have a portfolio of about 50 to 60 products that we've built internally. And many of these, the last few years, have been large language models. So what happened in 2021 is we were part of an advisory group with the Gordon and Betty Moore Foundation. This is Gordon Moore's family foundation, the namesake for Moore's Law. And they were very ahead of their time in really understanding that AI was going to transform medical diagnosis. And so they identified a few sites that were doing great work, and Duke was one of them. And they came to us and asked us, what would it look like to scale these capabilities? And I just have to emphasize, that was not something on our radar at all. We were doing great work internally. we were building really cool things, but this just got us into a different headspace of now thinking about the potential impact of these tools. How do we build capabilities at national scale? So the first year that we ran that program, we really focused on creating a set of best practices that would be freely available and anyone could go learn about and put those into practice. What we found, though, was creating great content and putting it online doesn't actually mean that people use it. So big surprise, if you build it, they won't come. I still encourage people to go look at the content. I think it's great. But we went back to the Moore Foundation and we said, okay, we need to do something more structured to help organizations go through the life cycle. And so let's try to define a starting point. And so we agreed on, okay, we're going to run a 12-month program where people come in with a problem and they identify a commercially available solution. And then over the course of 12 months, we'll help them evaluate the commercial solution, undergo the negotiation and contracting, all the security and privacy concerns. We'll help them design pilot tests, what should be the outcome measures that they measure, and then leading up to testing the technology and then making the decision to fully operationalize. So that's what we called the practice network, and it's the technical assistance program. And I just have to say that work has been incredibly meaningful. It's really two-way learning. On one hand, you have organizations like Duke, like Kaiser, like Mayo Clinic, Michigan Medicine, these large, mostly academic organizations that are essentially now volunteering their time to serve as mentors to the 4 federally qualified health centers and 1 community hospital. So for the technical assistance participants, we're taking their use case and then finding the people who have published on that use case previously. And we're recruiting them into the network. And then we set them up as mentors so that once a month they get on phone calls with these sites and help them work through challenges that they have. We also take them through the resources that we had developed in more of a structured way. I want to emphasize that there's challenges in the safety net that are very different than the big organizations. One is that the products really do perform differently. For example, one site along the southern border with a very large Hispanic Latinx population, they're implementing an FDA-approved diabetic retinopathy device, and the rate of images that are unreadable by the technology is an order of magnitude higher than what the vendor anticipated. Another is a federally qualified health center that wants to implement the Epic no-show algorithm. And they found that it really did not work well on their patient population. So they're looking at, well, how do they build their own or validate their own on their own data? So these patient populations are different. And I know that I feel like Todd just mentioned this, that it is different than the urban populations or other places that use their data to build these tools. The other is these sites can't leverage their purchasing power to negotiate with vendors in the same way. They're looking at shorter pilots. They're looking at more vendor lock-in. We have an organization that uses eClinicalWorks. And so the best-in-class AI scribes are not even available to this site because they don't integrate with eClinicalWorks. So there's a lot more just market friction that the big organizations are able to kind of work around. One thing I want to emphasize is that we do really believe that healthcare has tackled things like this before. I know that in my prior conversations, I mentioned extension of community health outcomes. So Project Echo out of New Mexico, that is definitely an inspiration for us in terms of how to have a hub and spoke model that diffuses expertise outside of these high resource settings into community and rural settings. We also have done things at a federal level, like regional extension centers, HRSA-funded telehealth resource centers. In the current environment, I don't know what's going to happen at the federal level, which is why organizations and groups like yours are particularly important. And I want to make sure to extend this offer and continue to extend it, that we would be thrilled to be able to work with folks in Maine to put together a model for what technical assistance can look like, leveraging the expertise you have within the state. However, we can help complement that with expertise that exists across the country. There's a phenomenal network of people who are at the cutting edge and are already in touch, sharing their learnings across the sites that we work with.
Super, great. Well, thank you so much. Just to stay with you for 1 minute, because I know you're going to have to go soon here. To drill down a little bit, are there specific AI applications that you've seen particularly particular interest or success in adopting across the, say, the 4 FQHCs you've been working with?
So I have the privilege of working in a organization that has successfully implemented many. So I'll speak a little bit about my experience at Duke initially, especially because Todd was just talking about an ACO. So when I started this work in 2014, 2015, many of our first use cases were actually chronic disease management. And I want to emphasize that value-based care and payment models that incentivize the avoidance of bad adverse events that are predictable, they are highly motivated to adopt AI to prevent chronic disease progression. So we did projects with our accountable care organization where we were predicting dialysis crash starts and then intervening upstream, predicting lower limb amputations for peripheral artery disease and intervening upstream, and then also inpatient death to run a community-based palliative care program. So I think that there's a lot of opportunity where you have value-based care to incentivize the investment in the technology to intervene and prevent these adverse outcomes. And then the first speaker, definitely 2 of the 4 FQHCs are looking at AI scribes. I will say that one of the frictions is that, I mean, obviously the current environment, there's a lot of financial pressure. And these organizations went into the experience really optimistic that there would be a financial ROI and that they would be able to increase patient volumes and increase revenue. I think that they're more open-eyed now that that's probably not going to be an impact that they see. And the primary ROI is going to be physician burnout. But I will say patient no-show and models to predict patient no-show. The clinic we're working with on that use case, they have a 30% no-show rate, which is huge impact to top-line revenue. And they're approaching this through an equity lens of not wanting to double book patients, but wanting to offer telemedicine visits for patients who are unlikely to show up for in-person visits, offer transportation assistance. So I think I've definitely appreciated working with FQHCs, how to make sure for them that they're not putting themselves at worse financial risk, because I think many of them already are concerned about just keeping their doors open in the next few years.
All right, well, thank you. We're gonna move on, but thanks so much for joining. And I understand you might have to sign off at some point, but we really appreciate you making the effort to join, and we'd love to figure out some innovative ways to work with you in the future. So stay tuned.
Thank you.
Rebecca, I'm gonna go back to you next. So clearly you've done a great job in piloting some of these models, making documentation, and you mentioned expanding to more clinicians. Can you just talk a little bit more about what that looks like as you go across maybe other departments, sort of bringing some of these things to scale, things you found that are both successes maybe or challenges as you've expanded your processes?
Yeah, thanks, Lisa. We are at a stage of our project that it's kind of taken off on its own. I think early on, we were able to recruit people who we identified people who were struggling with their documentation to be our early cohort, thinking that those would be the ones that would benefit the most from the use of the tool. And that was certainly the case, although we recognized early on that it wasn't the tool for everyone. This is not everyone's solution. But that being said, we kind of word of mouth and early successes and a few sort of vocal champions basically, you know, got the word out to their colleagues. And I think our medical group and our health system also played an important role in, you know, looking at our data, early data and our successes, and it sort of got interest, it promoted interest. And at this point, we're not recruiting, we don't have to. I think we daily get emails from people who are interested and want to get on our wait list, and we're booking into the fall.
So on the flip side, do you have safeguards in place to prevent maybe downsides of too rapid expansion, or people maybe aren't using it?
The limitation, I think there's no, the primary limitation is our ability to support our users. It's can be pretty plug and play, and many people can just sort of get started and don't need a lot of support, but there are some folks who need a little more hand holding with getting started in particular. And so that's been our sort of sensitivity as we've rolled it out, and we don't want to have too many people going live each month at a time, so that we want to be able to make sure we can support those users. We're very deliberate in offering training sessions pre, we have drop-in sessions post. So, you know, providing a lot of opportunity for people to talk to colleagues and ask others to, if they're having trouble. We're also doing outreach to people who have sort of signed up, but haven't taken the plunge and haven't really started using. And we reach out to them. We have our application support teams reach out to see whether, you know, would it be helpful to meet with them to really go over how to use the tool. So it's kind of got a life of its own, and the pace is based on sort of the ability of our support teams. I will say too that where our focus has been in the ambulatory setting, but we have a pilot starting this month in the ED, the emergency department. So our emergency room physicians will be starting to use it. And we've just heard that we will be able to roll it out to our inpatient providers as well, and looking forward to that later this year. And then in addition, Michelle Duvall, who was here earlier, is working with the team to develop a pilot for inpatient nursing to help address some of their documentation burdens as well.
Super, thank you. Well, certainly more questions about that, but we have just another minute, I think, before maybe our Dartmouth
Yes.
colleague is going to join. So Todd, back to you. You talked about governance, being very thoughtful. How do you, as you approach this, how do you balance issues of patient safety, ethics, risks, confidentiality? How are you folks approaching those issues that need balance?
Well, again, currently, providers, we've only approved the use of two specific large language models. Open evidence one is one which is a compliant tool. Partners with Mayo Clinic and New England Journal of Medicine. It's you know, all responses are evidence based and referenced. You know, not great for generating documentation, but is quite adept. It definitely scored better than I did USMLE. So so it's very good at medical questions. Okay, it's not the most. It's a direct communicator. Let's put it like that. Okay. But some of the other large language models for example, like Doximity GPT, which likely uses a large language model that a similar large language model as ChatGPT, but then they've fine-tuned it with some additional training and then created a HIPAA compliant front end for it. So you can paste in patient information, it generates the documentation, and will spit it out on the other end without exposure of any PII or PHI. So those are the two tools that are approved for use within patient care. We don't use ambient AI right now. We had another hour to talk about why we decided not to use ambient AI yet. Maybe at a different point, but we have a live remote scribe program. So many of our providers do have scribes, but it's another human being on the other end. So there's a lot more to talk about. I heard the timer go off, so I'll stop. But
We'll have more time afterwards. Sorry to short, but
So,
yes, thank you.
okay. First of all, panelists, I do want to thank you for a very interesting conversation, and we will extend the conversation and hope to hear from you now. I hope that you have the opportunity to stay. I would like to now welcome Dr. Nick Jacobson, who is from Dartmouth, to present a case study of his work. I know we only have a few minutes of your time, Dr. Jacobson, so we want to be prudent with that. And then we will give it to you, have you take it from here, and we will entertain discussion for the rest of the room. We'll entertain discussion after that.
Okay, great. Thanks for the invitation to present with you all. Are you able to hear me okay?
Perfectly.
Yeah, okay, good. So I'm going to be talking about work that we've been doing over the last about 6 years now, really in using AI for psychotherapy. And really trying to develop the first validated generative AI chatbot for mental health. So mental health is exceedingly common and occurring in about 1 in 3 people in any given year. Really quite impactful in terms of individuals and society. It's a leading cause of global disability worldwide and is associated with all-cause mortality. Unfortunately, most folks, and this certainly would include Maine, do not receive minimally adequate mental health care. This minimally adequate bar is really a low bar. It's like a single session with a mental health provider of any kind in a given year. We have a scale problem. We're orders of magnitude off of where we need to be to actually treat the number of people we would need to. It's between 1,300 and 1,800 patients per year that a care provider would need to treat just to treat and have fully impact anxiety and depression. And like a full caseload of a psychotherapist is about 26 on average. So we're way far away from where we need to be. Digital therapeutics are a class that has emerged to try to treat folks at scale, and they have really advanced the accessibility of treatment. One of the things that they're challenged by, though, is massive drop-offs. Most folks that use a digital therapeutic are gone, especially within the first 3 days. So you see this prototypical hockey stick pattern with engagement. And a lot of this is how it's really a lot of these have been evolved over time, where you've taken what used to be evidence-based content that was meant for psychotherapists to deliver in psychotherapy, converted to online media, and chatbots have been a way that try to break this down into more engaging ways. Chatbots have been used in the mental health space for about 15 years now, and there are some folks that call themselves AI chatbots. The vast majority of these AI, the vast majority of chatbots, aside from the past about 2 years, have been structured chatbots or authored chatbots. These are chatbots there. All of the content has been pre-written ahead of time. You all have interacted with these types of conversational agents. Absolutely, in customer service settings, customer service loves them. And I think they really can appear in conversational media, but they do not feel conversational. And that's part of why they don't work all that well, even though they do potentially improve engagement a bit. We have done work in this area, and they have some marginal effects. It does decently well at producing small effects. But generative AI has the potential to really transform what could be possible in this media, in part because of its level of personalization and tailoring. A lot of what's been possible in these structured chatbots is really a very rudimentary form of navigation and content, and you can't predict the conversational flow. But generative AI can adapt in ways that are very human-like, I guess, in terms of the capabilities, which is a lot greater levels of personalization that has existed in prior digital interventions. So we set out to actually develop a generative chatbot that could dynamically respond to a user with a therapeutic response. I think in terms of how these models really work at their core, they're based on advances in deep learning. They really learn best from dynamic examples, and they're based on a lot of modern advances in time series. So we started this journey in 2019. I'll tell you a little bit about the full course of the journey, abbreviated. The first version thinking about this was that we needed a lot of data. So we started with where data was easily accessible with mental health peer-to-peer forums online. We trained models, the first generative models on this at that time. And this is what both the input of this model would be and the output. And the input is, essentially what we would want for a user. We envisioning a user saying something like this, and then the output being the therapeutic response, or what we're hoping was the therapeutic response. And so our first interaction was, I'm feeling depressed. Sometimes I don't feel like I don't want to get out of bed. And then the response is, life is such a struggle. Most days I don't know how I have the energy to go on. I end up wanting to cry alone in a corner. I just want my life to be over. Very much not what we were going for. So our next iteration, okay, let's do something that's easy. We clearly just need lots of training data again, was our next thought. And so we went to psychotherapy training video transcripts. So these are what psychotherapists are learning from. This is like, we've got thousands of psychotherapy training videos, and we used these sessions as the next iteration of this, thinking, of course, we should use clinicians. And then we interacted with these models, and this is very representative of what the interactions look like. You'd say the same prompt. I'm feeling depressed. Sometimes I don't feel like I want to get out of bed. What do you think I should do? Go on. What do you think? I don't know what else to say. I want some help. And your problems stem from your relationship with your mother. Really not doing well.
Hey, Nick, just weird. There's some of the slides are hard to see. It looks like you may have some Zoom stuff hanging in front of your screen share on the right side.
Oh, interesting. Okay. Is that better?
Just not seeing the bottom right now.
Okay. All right. That'll probably just persist, and that's fine.
That's all right. Let's roll with it. Keep going.
Yeah, so we're gonna, we started then using curated expert content as the main next steps of what we were working on. And so we developed this data in-house, created it by hand, and we figured at this point that the data was the real bottleneck. We had the wrong data. And so about 1 in 10 responses of the responses that were, based on these psychotherapy training videos was good. But within 6 months of our team really developing this in-house, we got up to really a massive increase in the effectiveness of the interventions over time as we were evaluating this. So we spent the next several years just focusing on increasing the fidelity of the treatment that would be provided. We have spent over 100,000 human hours at this point on this, with a team of over 100 people that has been designing the system. So 6 months before the launch of ChatGPT, about 9 out of 10 of our responses were actually gold standard style of responses that we'd want. And we were pretty satisfied on the fidelity end, but then we worked the next 2 years on safety before then testing this in a randomized controlled trial that I'll talk about in a moment. So this is the system. It's called Therabot. It's interfaced through a smartphone application. We tested this and published these results about a month and a half ago or so in the New England Journal of Medicine AI, one of the top outlets in this area, and conducted the first randomized controlled trial of really a system that was actually clinically designed for this, for clinical populations. And so the design for this was really a randomized controlled trial where folks were either randomized to receive the intervention condition, Therabot, for 4 weeks, were asked to use it, and continued to be able to access it for the next 4 weeks, but weren't prompted to do so. And then outcomes were evaluated at both 4 and 8 weeks across both the waitlist, control condition, and the intervention condition. We had 3 different clinical groups. Folks that screened positive for major depressive disorder, screening positive for generalized anxiety disorder, or being clinically high risk for feeding and eating disorder. So these are not easy populations to necessarily treat. And we had folks that were at pretty moderate to high levels of symptom severity. So not just the worried well, as some folks might want to think about within the digital intervention space. A lot of these folks are the same type of folks you'd see in real outpatient clinics. And these are all of the primary results. All of them are significant. All of them are large. The effect sizes that we saw were really, this is the predominant way that you would evaluate the degree of change that happened within the treatment group relative to the control group. These are really comparable to the effect sizes that we would see actually in the best gold standard treatments that we would have in each of these settings. So delivered in person over a longer period of time. Folks developed a really strong working alliance with us that was really comparable to what is the ratings that psychotherapists have with their providers, meaning that this is really important because this is the bedrock of psychotherapy, being able to trust your psychotherapist as the most well-established, empirically supported, evidence-based part of psychotherapy that works. So that was a really good sign. Folks liked it, and engagement was really high and sustained across time, with folks using it for over 6 hours on average. So the key takeaways, I think, from this is that the data quality is really crucial, and I think this really demonstrates that this type of well-designed generative AI system can serve as a standalone intervention that can have really large differential impact with strong engagement. And I think it's a promising tool. I think this does not generalize to all settings. So I'll probably end my my screen share there and talk a little bit about the applications of this within the general space, because this does not generalize well to other settings. When we talked about designing this over the course of 6 years with this intensive amount of work doing so. If you use and try to interact with the foundation model, including today's foundation models, the large commercially available ones that folks are actually using for treatment now, they will very often not provide you what an evidence-based response is. And it's often not only not a benign response, but it can be a harmful response. So the harmful response can be pretty significantly harmful. And can be delivered at large scale. So this happened particularly pretty recently in the case of OpenAI and the release of their 4.0 model. There's a lot of folks with psychosis that really interacted with the model in ways that were profoundly harmful. So it became sycophantic, for example, and it endorsed a lot of folks that were psychotic, telling these models that they were not going to continue to take their medications, and it was telling them that to support them in their efforts. So I think these types of systems really should have some regulation around them to do them well, but I think they can act in ways that are very effective. In terms of the regulatory space that they should operate, in my mind, I think there are pathways that this has been explored, and there is some models that could be used. This is not an entirely new field in terms of its delivery, although the technology and the capabilities themselves are new in some areas. I think the framework surrounding what I think is a useful regulatory mechanism behind this is really attaching it and evaluating it in the same framework we would digital therapeutics, because there's these act in very similar ways in terms of thinking about how to evaluate them. I think the safety and the efficacy of them are really empirical questions that need to be demonstrated related to claims that one's making and how the settings that they're actually being implemented in. I am about out of time. I hope that this is at all useful. I probably don't really have time for any questions at this point, but I'm sorry that I could only join for such a brief stint, but thank you for having me.
Thank you for joining us, Nick. We appreciate it. I think your path and your journey is informative to this group. So I do appreciate you taking the time you had available for us.
My pleasure. All right. Bye-bye, folks.
So we knew Nick only had a brief period. We do want to rejoin the conversation and really dig in a bit with this group to everything we've heard. What I might suggest for now is a brief break. It's about 3 o'clock, so why don't we plan on being back in our seats at 3:10, and then we'll kick it off, and I think we'll shift over, and Mary, you'll lead us through the remainder of the conversation. Fair enough? So to the almost to the end and off to the right. So 10 minutes and we're back here. Good.
Okay, you ready? Everybody settled in? So we heard some amazing talks and really great speakers. So we want to open up the discussion and I want to prompt you with these thoughts before we begin. What stood out to you most about the speakers that you heard from today? How does it align with your observations about how AI is beginning to shape hospitals and healthcare institutions in Maine or other rural areas? Do we have the right questions to be assigned to the subgroup focused on this topic? And is it resonating in the right way? Are there any gaps that we're really missing? And I know that Molly Kern-Rolls and John Brodigham also have thoughts on this that we talked about ahead of time. So I'm going to open up the discussion with them and then with everybody else. Molly?
Yeah, we have Molly. I'm here.
Oh, Molly. Oh,
Yeah.
that's right. Molly's the person that told me that.
No problem. Yeah, so I mean, it was really helpful to hear about Therabot. I think, even in the room, the reactions to seeing the potentially harmful use cases really causes a real reaction. And at the same time, thinking about health access and how dire the situation is with regard to mental health access in Maine. And so kind of, positioning both this incredible need and this potential really important tool with the downsides that I think were clearly presented. It is amazing to see how a really sensitive project can be designed, and the amount of expertise and time that went into this seems really remarkable. It raised a lot of questions for me about what are the guardrails that need to be imposed on all projects that purport to do this kind of work. So, what would we use to evaluate or assess the adequacy of any protections, and what kind of protections would need to be there? Because it doesn't sound like that probably is something that we can anticipate making happen in every circumstance where we're offering a new tool. But what are the really critical elements of that example that would enable us to have a high quality product that doesn't cost?
You bring up a really important principle, which is, I don't think specific to healthcare and AI, but broadly, this tension between waiting till something is perfect until it's good enough. And that answer, I think, is going to be variable depending on the use case. Obviously, if someone's life is on the line, you want to tend more close to the perfect. But I think it's something that we'll, as a society, have to wrestle with this technology.
To carry on from that, do you think that the mental health chatbot can be improved by having biometrics or other types of data support that would help to define its use in certain circumstances or add feedback that would help physicians make decisions?
So while, you mean during the conversation, have biometrics to inform, she's getting sweaty, or he's getting, his heart rate's going up or whatever. Yeah, that's interesting. I hadn't thought about it, but that's cool.
Mary, can you repeat the question? Some folks on the line.
Yeah, the question was, so the chatbot is, so they're going through these variety of scenarios and questions. It's a shame that we don't have the expert here, but I was just wondering if in some of these instances where it's using this kind of chatbot type, feedback, if you combined it with other information like biometrics, like heart rate, like indicators of stress, or, I wear this Oura ring, it tells me like most of the day I'm stressed, which is not but things like that would allow some real-time feedback into the biology of the patient, physiology of the patient at the time that they're interacting. Seems like it would also improve the large language model, so it would really be able to kind of improve the fidelity of the feedback, and also add some safeguards into warning zones where people are, there's a lot of research in mental health that I've seen that really aligns these, Fitbit type experiments with the being able to predict episodes or deterioration of the condition. So I'm just wondering if that's useful in some way.
Yeah, I'm not sure if it's been looked at, but I agree. It's a great idea.
So I actually do know, says over a year ago, I was having, not in the AI task force sense, but in work that we were were doing a conversation with an Apple AI engineer. And it was not about healthcare, but we were having this conversation. And he said, we have listening technologies. We've already experienced some of those. So what we don't have in the raw digital format is any way to contextualize them. And forgive the example, but he used an example. Imagine we're sitting here having lunch and I'm joking with you and say, oh God, I could kill you. Versus a conversation that is a threat-based conversation. And how would you interpret that? And he said, and I wear an Apple Watch, and he said, if we have your Apple Watch data, we can detect your heart rate. We can detect other biometrics that help inform the verbal data. So honestly, that scared the jeebies out of me. Can you keep that? Can you keep that in the hands of the good guys? That's a different conversation. But as has already been indicated, pace of change is so quick, and I think that those kinds of additive technologies are on the horizon. Interesting stuff.
Would you mind if I make a comment?
Not at all.
I mean, I'm fine to just observe, but I'm also fine to participate too. So you can tell me to shut up. The remote patient monitoring, there's tremendous opportunity in remote patient monitoring. And there are very large organizations dumping massive amounts of research and development capital into developing systems for monitoring, but even more importantly, validating the data that they are collecting. And one of the, I think, so there are many forms of novel biometric data that tells us a whole bunch of things. And one of the, I think, the most interesting ones that's happening right now is a lot of research on detecting individuals' voice and using a predictive analytic model to detect early development of certain chronic diseases, as well as decompensation of chronic diseases. And in that particular situation, that data isn't necessarily used to train the models. Okay, that data is used as almost like a population health analytic, if you will. The data that these systems are being trained on are standardized data that is validated through research, that's being done. So we're going to see a lot of experience.
John, I thought you might have some comments on this as well. Back to the sort of crucial question, are you really catching all of the things that we should catch in school?
Yeah, thank you. And I think it's been a fascinating conversation, and I was really particularly interested in Nick's thoughts on the chatbot innovations. Looking at this through the lens of sort of the older population, I want to go back to the remote patient monitoring idea. I mean, one of our policy priorities has been to allow people to age in place. And to a great extent, I think that my interest in the remote patient monitoring would be, how can it facilitate allowing more people to stay at home rather than having to go in a facility where they're in the presence of, medical providers all the time. Different kinds of smart devices, wearable monitors, vital sign monitoring and tracking, things like that. And generally, telehealth, I mean, is something that the older population, I think, can really benefit from if done correctly and thoughtfully. And also, just like kind of a side note, I don't know, there was some of you may have seen or heard the report this morning on public radio about socially assisted robots, which is not specifically speaking a sort of maybe a healthcare, it's more of a kind of a quality of life rather than a medical innovation. But there's a really interesting piece on how testing out socially assisted robots just for interacting with older people and prompting them to get up and move around, prompting them to do different things during the days during the day, relatively sort of simple and straightforward kinds of interactions. On the concern side, it's been mentioned, but validating the models to make sure that there's no age bias in the data and the algorithmic training is a concern. We think that that's going to be an ongoing need to do that kind of validation. And then again, the population that we work with is not the most digitally literate, and as people are interfacing with these kinds of tools and strategies, just to be mindful of the unique issues that would be facing this population in terms of their facility with some of the technology. And of course, we even, have people in various stages of dementia. And how would this work for them? So those are some of the thoughts and concerns that came up. But generally, this is a very encouraging conversation with far more on the benefits side than on the concerns.
Do people know, you brought up this sort of algorithmic bias or the local things that might be relevant in Maine or in rural areas that might trip up some of the more urban generated capabilities, and Mark brought this up in his discussion. Do we have any idea? Do we know yet what those differences center around? Do we have inklings into the research from where that bias is and how we could begin to address it?
Yes, and every model is a bit different. Again, large language models, right? How they're developed. They start with training on vast, copious amounts of data, right? So think about feeding a new model the entire history of human language, right? Every language, not just English, every culture, you want it to have all the good and all the bad stuff. So if you start asking it questions, then you're going to get potentially and probably very harmful, inappropriate, toxic type of responses, simply because it's accessing the inherent bias within human language, right? There's no way to bias from these systems, and actually, even at an even deeper level, these systems operate simply because they are able to make biases. So moving all bias is impossible. It's and it's actually required for the systems to work. But you can then, in the fine-tuning stage after that initial training, design systems so that they have those guardrails. You can develop governance. You can develop a set of rules that they must follow, and then provide a constitutional layer that then dictates personality. And it may not have, we were just discussing, you may not have all the information on a specific subset of your population because studies haven't been done on it. But the AI needs to understand the contextual aspects of who this individual is, and then be able to make a reasonable reconciliation of the data it has in that particular context. So giving the systems as much context as possible is key, and setting those guardrails so that they only give helpful responses.
So we may not know those elements of bias, but best to have systems trained here or here. It's kind of what you're sort of talking about data sets.
At the fine tuning level, I would agree with that. I think it would be a really massive and unnecessary lift to design an AI system from the bottom up. Because very good base models exist that have already been pre-trained, and then you access that, because that's all of knowledge. Right now, let's add the next layer of the knowledge specific to the work we wanted and how we wanted to.
Yeah.
I would just add, I mean, I think our concern at ACLU is seeing the ways in which broader societal biases are mirrored in many of these products. And so thinking about this as an opportunity, medicine's a great example where there were a lot of studies for a long time only on certain types of people, usually men, usually white men, right? So there was not a lot of information that was accurate for people whose bodies were different than that. So thinking about this as a chance to say, what would we do differently to create something that really does have the ability to ask the right questions of everyone and not make assumptions about who people are, what they need. There have been some studies, I think there was some good news coverage of this 2 weeks ago about a study where the questions that were asked, I think in a mental health context, were very focused, and what they figured out was that the bot was assuming a lot of things about the person, right? And so as they went in to find out, well, why did you ask this? Why did you ask that? It was, well, I thought it was a man. I thought it was a middle-aged man. I thought it was a white middle-aged man. I thought it was a white middle-aged man who lived in New York City. I thought, right? So I was offering all these suggestions that were relevant for that person that I had in my robot head, and not actually responsive to a variety of people or people in Maine in general, right? So I mean, I think that looking at the sort of civil rights components of this and breaking it down, I totally get that. Yes, there is a lot of information out there that has to be incorporated, and also the way that that information has historically been made available, what is retained, how it's retained, right? All of that has a real historical reality too. And so thinking about ways to put these bigger questions of justice into the mix and make sure that people in rural areas, people who are sort of underrepresented, are still included.
I wholeheartedly agree with all of that, but we also, these biases exist because humans have biases.
Yeah.
Can we use AI to retrain people who don't necessarily want to have, but they don't even realize they have biases, right?
100%.
So that is just something that come to mind.
That's, I think, a cool idea.
Sam?
Yeah, a lot of interesting points to reflect on from this. Just to follow up on this piece of the discussion specifically, I think it would be worth us including in the discussion questions a specific tag that we need to address equity in these systems. Because if we don't specifically proactively do that, I think we run the risk of that being kind of pushed aside. So I think that's worth considering. And I also think, as a representative of the AFL-CIO and to Dr. Kitchen's point, I think one of those pieces of context, one of the things that education workforce group can do is really think about how we can develop that kind of contextual knowledge to enhance what AI produces. And so we were talking earlier about Indigenous population in Maine, which from a numerical standpoint is a blip, several thousand or maybe 10,000 total. But they would have distinctive health needs that somebody who builds relationships, that has that knowledge could offer. And that would enhance the AI, but we need to proactively say that has to be built into the process, that has to be trained into people that are going to add that layer onto the AI and those models.
Well, maybe vice versa. So it occurred to me that when Rebecca was talking about, the systems that are really capturing the communication level between physician or provider and patient, there's really such a huge opportunity to take that information and use it as a training tool for new providers to really be able to hone what successfully draws the information out of the patient, maybe successfully connects with patients of different backgrounds or demographics or different nationalities or whatever it is, to be able to take that information, really turn it into a learning experience for, to enhance the workforce. I don't know if there are any efforts to do that in Maine now. Certainly access to workforce here is really important. Providers are not abundant. So how do we continue to think about that in the scene of AI? How do we help produce more better providers?
I think in the same vein as what the last couple of comments were made, when I look at the healthcare issue, and I'm looking at it like more of a 30,000 foot view. I'm an economic developer, and I'm in the public sector subgroup. But really, when I look at what the healthcare subgroup is supposed to be looking at is, you know, where does AI offer promise in addressing healthcare, and what are the barriers? And then the other question is, what can Maine do to emerge as a national innovation leader? In both cases, we're in a state where digital equity isn't good. Whether you're talking about knowledge, but also, you know, I grew up in Freiburg, which is served by Saucony Valley. There's a lot of the state that doesn't have internet access. And I think each of these groups, if I look at workforce economy and all of them, what I hope this group comes out with is the need to really amp up our digital equity. But on top of that, I work on trying to bring companies to Maine, and their number one issue is our power grid. It's not reliable. And so those two things, when I look at healthcare from the 30,000 foot view, you guys are delving in deep beyond my abilities and some of the stuff. None of that matters if people can't get access to it or the power grid is down. So that's sort of just my overarching kind of observation.
I definitely agree with that. And going back to the equity issue, we talked about it during the demo period. You know, something as quote straightforward as cellular signal impacts our population. So from a state perspective, if we can redouble our efforts, and I know we're already working hard on this, but to make sure that we get all portions of our state to have adequate infrastructure like that, I think that would go a long way. And that's not just AI, that enables all kinds of other services and capabilities.
Mary, can I draw our attention to our online numbers?
Hi, everybody. So I just finally got back from camp pickup. But I want to just emphasize that point about digital infrastructure. So one of the sites that we work with in New Mexico, and I would say this is common with the FQHCs that we've interfaced with, one is just broadband access. The other is having stable EHR systems. And once again, this is an example where these are less concerns in the big health systems. For example, one of our FQHCs is on, I think the product is called Centricity, and it's been retired. It's no longer supported in North America. They're having to apply for grants now to migrate to a new electronic health record. And that kind of puts on hold any third-party application investment, because really the EHR is the chassis on which you put things for many care delivery organizations. So at a state level, when you're thinking about what types of support or infrastructure investments are needed, just want to make sure that broadband and EHRs are part of that discussion.
Are there other things where AI could improve access to healthcare? I know Lisa and I were talking about this earlier. And Mark may have some thoughts from the implementation point of view, but can AI improve the time that you get to a physician, or the time that you receive care, triage? Maybe you can just. Well, I think it's a very relevant question. I haven't really heard a lot. I mean, I know, the consult system, some that you referenced, but that's real.
Can you go a little louder?
Yes, I was just heard a lot of discussion yet about AI to address that issue. We know there are backups in access to primary care, specialty care, behavioral health care. So just curious, and then, we know emergency department backups and urgent care, if anybody is seeing examples of that or have thoughts about how AI could help with that.
Yeah, I feel like, and maybe Todd has specific examples for SOCP, but the whole idea of triaging, using AI
Right,
to
exactly,
triage
right.
and prioritize,
Right.
and then you're freeing up
Right.
those clinicians, whoever they might
Yeah.
be, to deal with more acute or more, you're getting them in more quickly. And then you partner that with Picasso, with e-consult models, different things, maybe it's never one sort of tool by itself. I really liked how you said that, and I want your talking points too, so I can give them to our folks at HRSA. Because we're the telehealth resource center for the 6 New England states in New York, and we're getting asked a lot of questions across all 7 states that we serve. And I think the more we can maybe go to them at this point with guidance and recommendations, it could be really cool, and gets to the last point. I think that you like, how can Maine serve as a leader in this area? And just one final point, I'm a board member from day one for the Maine Connectivity Authority. We've just got to continue to be really connected. We've probably more than any other state, we had the first digital equity plan that was approved by the feds. It's high on the priority list, but we've disseminated $250 million in federal funding. Of course, the Digital Equity Act was just terminated, where we have lots of folks that are working to get it back in place, but to TBD. But I think having it be a core point for this group and many others is going to be huge. Yeah.
So to that, where we started though, on your note about triage and AI tools to assist with triaging, whether in a healthcare system or outside potentially. Have you seen that, or have others? Are you supporting that?
I think Mark has got his hand raised.
Yes, so lots of examples here. I mentioned before the chronic disease progression models. So what we found across clinical specialties is inefficient use of specialty visits. So going back to the nephrology example, there were patients who were being referred to a nephrologist who didn't need that escalation of care, whereas there were patients who should have had escalated care who weren't getting that specialty access. So that was one of the things that we did with the algorithms. We identified these high-risk patients and then actually had a centralized nephrologist review these cases remotely and decide, could they stay in primary care? Could they do an e-consult? So another form of just remote support to a PCP to keep the patient in PCP, or do they need an in-person visit with the specialist? Other places where I want to just call out large language models, we're starting to use them internally, is actually screening external consults for specialty services. So we have lists of heuristics that we run now on these inbound requests to help us prioritize who to schedule most quickly. The other place, and people don't usually think about this as access, but I think it is access, is prior authorization, where we have patients who are stuck in the hospital waiting to get approved for procedures or some more acute testing. And so now we're using LLMs to curate the content from the medical record to streamline submission of the documentation to insurance providers. That way we can speed up decision-making and approval so that people can get these treatments and procedures more quickly.
I did want to flag that one of the major concerns that I've heard from nurses, Nurses Association specifically, is the use of predictive algorithms in staffing decisions. There's a lot of distrust for those kinds of algorithms and general unease about that as a way of making decisions about how staff is allocated. So I think it's important to keep that in mind and make sure that nurses are a part of the conversation as we talk about these kinds of tools.
Yeah, one thing I'll mention is for the nursing types of activities that you saw earlier in the demos, and really everything that we do, it's all clinician led. The technology is sort of secondary. We go to our clinicians, frontline folks, to say what are the problems that you're experiencing, and how might we be able to use technology to address them. So that's sort of the computer vision stuff for the telesitters and so on. That's all clinician driven.
Yeah, can I just stay on the sort of triage AI for triage system? You were both nodding your heads when we were saying that. Are you using tools like that? Are you considering?
We're not, certainly considering, and I'll say the reason, and I think this is probably reflective of AI in the healthcare space overall, is we're proceeding cautiously, right? The first do no harm kind of thing. And so a lot of the use cases are more administrative types of things. They're ones in which they're internally facing. So the clinician that that Rebecca represented in our demo. It's helping them, but it's not necessarily impacting the care that's being provided to the patient. Secondarily, sure, but not directly. Once we get to that sort of diagnostic point, or where you're talking about potentially taking the clinician out of the loop, you know, with some kind of triage or something. At least we're taking a much more cautious approach. For certain, to Mark's point, there are use cases that are emerging that are starting to touch on this. And I'm certain that we will get there. But we, at least for ourselves, are proceeding cautious.
I think there's tremendous opportunity for improved patient satisfaction. And not only in the triage scenario that you're talking about, but really in any patient communication scenario. That there have been studies, you know, not on all models, but some models have been shown to be significantly more empathic than humans are. I've had that personal experience with AI, but I will say that it is much better and thorough in its documentation, notification of, you know, abnormal labs, right? You know, it doesn't just say, you know, hey, this was abnormal, not worried about it, I'll see you in 2 weeks. You know, like that's how much time I have to dedicate to it. But in less time than it took me to type that, I can have an extensive response that gives very clear reasoning behind the decision making and a very thoughtful, kind tone. And I think there's a huge amount of untapped potential for every member of the care team to leverage that type of improved communication to improve the patient's experience.
Going back to the questions around workforce development, as we have workforce issues in all sectors at this point. I think what is clear is that everyone AI is going to infiltrate everywhere. And what we need to do is educate the public and learn how to use it smartly and implement it smartly and have the guardrails in place and the safety concerns, and so that people don't sort of go blindly into using these tools. We don't want harm, but it's clear that it's going to become an essential tool in all areas, but particularly healthcare. Our caution in the areas of patient care and wanting to do no harm is critically important. But at the same time, people, young people coming into healthcare, the expectation needs to be that they need to learn how to do their job with AI.
It may be of interest that we have clinicians who are thinking about coming to work for us, and as part of their interview process, they're asking folks, well, what kinds of AI technologies do you have deployed?
Well, and I think if your outcome measures really around improving, burnout or getting rid of burnout, improving burnout sounds weird. But I mean, that's sort of the advertisement, to be in a place where you have these tools where you would want to, that's where you want to work, where there's advantages for you to thrive as a clinician in that environment, not to be, I just want to flag Mark looks like, oh, sorry. I can barely, Mark, okay.
Just one thing I want to call out to give credit to FQHCs and acknowledge a place where I think they actually excel beyond the academic medical centers is they have patient and community representatives on their board. And so for the FQHCs that we're working with, they're actually much more deliberate about creating patient-facing content to educate their patients about AI tools that they're planning to put into practice. So just like a very concrete example, we have an FQHC that was going to start this pilot for a generative AI tool. And so they asked us, can we get some of the content that the big systems have put in their patient waiting rooms. And so we reached out to the core sites that we work with, and nobody had any flyers or things. So they built it, and then we shared it back with the larger organizations. So, I mean, I just want to emphasize that it is two-way learning. And in some ways, I think the safety net providers are more attuned to these sensitivities than big places like Duke or Mayo or, yeah.
Yeah, I just, in the presentation on the ambient medical info, I was, I think later Mark mentioned something about the pressure that could be put on the financial element and the ROI, just, getting through people more quickly. And it didn't sound like that came up as a factor in Maine Health thinking about this at this point, but I wanted to just put that back on the table because I think it's an important thing for us to be mindful of that.
Yeah, I think there have been studies that have come out that as a secondary benefit of the use of these tools, that some organizations do see an increase in coding, level of coding, and also increase in volume. Maine Health made a deliberate decision. They did not implement this tool in order to increase volume, but to really address the sort of documentation burden and burnout issues. And I think they're certainly hoping to see some financial benefit from that as well. But that financial benefit, as we touched on earlier, could be, better retention, better recruitment. Losing a doctor, it's very expensive for an organization.
Yeah, but if you can bring patients to the care provider earlier, however you do it, get diagnostics run while they're, it's so frustrating to wait, 3 or 4 months, you might see a care provider only for them to tell you, you have to go get blood work done, and I'll see you in another 3 or 4 months. I'm like, So if you could improve that cycle and condense that, and I mean, there has to be a revenue increase that goes along with that. And then it might also entice diagnostics company, Wes or whoever else is doing blood work, to come into the state in a way to see the progress of really improving the ability to get a test run and to reach out to people and improve their business model. I mean, does that make sense from an economic development standpoint for the people who do that work?
I guess since you mentioned that, I'll just say to build on your specific comment, I mean, throughout this conversation, for which I really am a layman on healthcare, the triage conversation I've had too, so that's my mind. One, I would love it if, like what you were just saying, that somehow these tools unlock the ability to, whatever it may be, speed up the process, open up more availability. That, people I know close to me basically have given up on finding a primary care provider at this point. It's a struggle, I would say, to my end as well. And there is this idea of, fortunately in my case for health insurance, I am in a situation where I don't have to go through the primary care to get a referral and so on. And so to one of the comment earlier, I am able to make the decision on my own. It's like, I'm just going to go straight to that physical therapist first, because that's 2 weeks instead of 3 months to go to the primary care and then schedule that. On the other hand, if the triage angle is, a scenario I don't want to end up in is I have to go through my insurance's AI to get approval for a referral, right? So the physical therapist, instead of having to go to the primary care, it's like that. As the layperson, future patient, I don't like that very much.
Yeah.
But I do think, just on the economic development note, that is, I think it is both inherently a constraint on affordability and income in Maine, when you have a constraint on something as fundamental as healthcare, due to a shortage, broadly speaking, of providers, as well as I think for to the extent we need to grow our workforce. I think not everyone, but some people do consider that when they're deciding where to live, where if they know that they're not going to be able to get. Another problem is you might not know until after you do, but let's say hypothetically you do know that you're functionally not going to be able to get good health care if you move to a particular, especially rural part of the state. That's a problem. for our economy generally. So few thoughts, go on, but that's what I was thinking.
I see, you know, if you touch on access to getting doctors. You know, the healthcare industry has already done a great deal of changing, because since I was a kid to now, you have physician's assistants now, and you've got, you know, different categories of employees. So that you don't have to necessarily just go straight to the doctor. And now I can see with AI, that's going to change what your workforce is. You may get more to a point where there are a lot of technicians, so to speak, who are delivering at least the one-on-one healthcare with the patient, yet they've got a device or a scanning thing or something that's reporting in, and then the doctor has, you know, the human touch to look at more of it. Type of thing. You know, I really think of the challenge that he was saying, because I also don't have the type of healthcare where you got to get a referral, but I have to go to physical therapy for something. I set the appointment for like 3 months out. I'm like, 6. I was hoping to be better by you know? So
Okay. If I interrupt, I hate to be the guy that always interrupts the great conversation, but we did want Scott to be able to give us sort of an update on where we are, where we're going, and make sure that we're on path to meet our objectives.
Terrific. Thank you for the save, Dan. Nice to see you all. As a reminder, I'm Scott Kleiman from the Governor's Office of Policy Innovation and the Future. You all get lots of emails from me, and most of you tolerate them. Thank you. So I'm going to give you a little bit of a sneak peek of what's ahead. I do just want to take a moment to look backwards and acknowledge one person in the room, Dan Ketterat. Dan was a fellow with our office last summer, and then subsequently has been working with the DHHS team on doing a lot of research about the state of AI in Maine, and also in particular AI in healthcare in Maine. So thank you, Dan, for all the research that you have done behind the scenes. You've been a really great person to be part of the team here. So believe it or not, you all are about halfway through your time on this task force. We have a October 31st deadline from the governor for you all to deliver recommendations to her. And so that gives you about 5 more months to get this work done. So what's the plan for that time? So Dan, if you would hit the next slide here, if you would, please. Are very fancy. So you all kicked off right at the beginning of January to get to know each other. And then this spring, much of the work of this task force has been what I think of as these exploratory conversations. The task force identified these 6 areas that I was interested in going into more depth. Each of these task force meetings has been about hearing from local practitioners, and also bringing in some national experts to testify and help this group explore those topics. In parallel, we now have 6 subgroups that are going in depth in each of those. And those subgroups have been charged with beginning to shape recommendations that the task force as a whole can consider. So we've been looking at the questions. Those questions are teed up for those subgroups. As they answer them, those will form the beginning of the recommendations for the task force to continue. That work will take this group through July, I should say. There are no task force meetings in August. You can't do that in Maine, as you all know. And as you all get back together in September and October, there are 4 meetings on the books across those two months. And those will be important meetings. So that time will be about going from this exploratory phase and back to convergence. So synthesizing all of the different themes that have come up, the recommendations, the ideas that have come from subgroups, and taking those into recommendations from this group and ultimately a report from this group that you all will submit to the governor and the legislature on Halloween or before Halloween. Our co-chairs have suggested identifying at least one of those meetings in September, October to try and get back together in person. And so we'll be trying to work with you all to find a date that could work for that. So I'm happy to take any questions, but I just wanted to step back a little bit and remind you all where we are on this journey and preview a little bit about what's ahead for the second half of this work. That's it for me.
Good.
I think then we go into our wrap up, right?
That's,
Okay.
yeah.
Our next meeting is Wednesday, June 25th, 12 to 2. The topic is AI in the public sector, so we're excited for that. A final thank you to Dan and his team, Rebecca, everybody here, just incredible hosts, really educated us well, really brought a practical, tactile flavor to this, which I thought was really fantastic. And really thank all of our guests and visitors who participated and everybody for the fantastic conversation. So thank you so much.
Dan, I actually have one very tactical, basic question. It applies to me, but it probably applies to everybody. Do we have to go up and out and sign out? Or
No, you mean, are we gonna hunt you down if you don't sign?
I've heard the Maine Health Police are just, sort of. So we can use the back door if that's more convenient. Okay. Oh, that's where they find me most often.
We'll have you on a.
It's oftentimes the only
You
way
ever
I
show
can
up
get
at Maine Med?
You ever had to park at USM?
Yeah.
Yeah. Those, they'll hunt you down for sure.
I think we are officially adjourned. Thank you.
All righty. Thank you.